Uh, my dear participants from home and abroad, Assalamu alaikum, and good evening, good morning to everyone. It's my pleasure to welcome you to this Public Health Cafe webinar. My name is 𝗖𝗬𝗃𝗲𝗄𝗏. I am former Director General of DGAP, Ministry of Health and Family Welfare. I will be moderating today's session. And you are aware that the webinar is organized by the Department of Public Health, IUBAT, College of Nursing, Public Health Foundation, Health Systems Matter. And this webinar is organized once in a month on pressing public health issues. And so far, we have organized a good number of seminars like this. And this webinar will be chaired by Professor Dr. MD 𝗖𝗬𝗃𝗀𝗶. He is the Director of National Institute of Preventive and Social Medicine. Dr. 𝗖𝗬𝗃𝗀𝗶 has a great passion for public health. He has been working in public health sector for a long time, and he is also teaching part-time in Public Health Department of IUBAT. Welcome, Professor Dr. MD 𝗖𝗬𝗃𝗀𝗶. And we are fortunate to have a number of acclaimed panelists this evening. The panelists are Professor 𝗕𝗫𝗀𝗃𝗏 mohsin. She is the professor in Khulna University, and she has been working on her research focuses on the cost of care for non-communicable diseases, particularly cancer. And you know, today's webinar is on cost of cancer care in Bangladesh. And Dr. 𝗕𝗫𝗀𝗃𝗏 is also, her research work is evidence-based and led to discussions on financial protection, affordability, and sustainability of healthcare systems. So we are happy to have Professor 𝗕𝗫𝗀𝗃𝗏𝗏. And our other panelist is Dr. 𝗱𝗏𝗃𝗀𝗃𝗏𝗃 Taposh. Dr. Taposh is working now as Senior Consultant Oncologist at Evercare Hospital, Dhaka. And he did his MD in radiotherapy from Bangladesh Medical University. He holds a diploma in palliative care from Institute of Palliative Medicine, Kerala. He has also advanced training on cancer care from National Cancer Center, Singapore. His clinical experience spans comprehensive cancer care with a strong focus on patient-centered oncology. We have three other panelists. I think I should introduce them as well so that we can go to the discussion from 𝗕𝗫𝗃𝗀𝗃𝗏 next time. So the next speaker is Dr. Alex Barland. He's a Senior Health System Executive, Consultant, and academic with over four decades of experience. And Alex Barland led different reform-oriented initiatives related with reputed organizations like World Health Organization, World Bank, OECD, Canadian Health Authorities, NGOs, and universities. Alex Barland is also Vice President Clinical Operations at Vancouver General Hospital. And Mr. Barland has held academic appointments at the University of British Columbia, Simon Fraser University, and IUBAT. And he has a extensive number of publications on health governance, systems thinking, and global health education. We have seen Dr. Javed Iqbal. He's already joined. Dr. Javed Iqbal is a senior pathologist with extensive international training and experience in oncologic pathology. He did his MBBS from Dhaka Medical College. After that, did his PhD in molecular biology from Allegheny University, Philadelphia. He had fellowships in some hospitals in New York and also fellowships in oncologic pathology at Roswell Park Center Institute and hematopathology at Drexel University. He is involved in advanced diagnostic pathology, supporting cancer care and precision medicine. And last not the least is Professor Dr. 𝗖𝗂𝗁𝗲𝗄𝗧. He is the chair of Department of Public Health, IUBAT. He earned his PhD in public health from the University of Alberta, Canada. He has more than 20 years of global leadership experience. He was advisor in the Gavi Alliance. He worked in the, he led the endangered health in Bangladesh. And also, he was country director in Management Sciences for Health, and he led this project in Bangladesh for nearly 4 years, and contributing to large-scale health program across multiple countries. His expertise spans health systems, global health policy, and public health education. So it was a long introduction for the panelists, but I thought that I should say more because each of the CVs are so illustrious and so rich. I only just skipped and picked only a few points, but still you are more than what I have mentioned here. Distinguished participants and my students of MPH and other students, we again welcome you to this webinar. And you are aware that the webinar is for only 60 minutes. So we'll listen to the panelists first, and then we'll have a question and answer session. Meanwhile, if you have question, you can also question or comments or any sort of reflection, you can mention those reflections in the chat box. If necessary, the experts sitting here may address your queries or your reflections. So, and after question and answer session, today's chairman, Professor Dr. 𝗖𝗂𝗁𝗲𝗂𝗀, he will give his reflections and concluding remarks. And at the end, we'll do the wrap-up. So we all are aware that cancer is a big problem, not only for Bangladesh, but also for the globe. I was looking at some report that the cancer incidence globally, it is rising continuously. And now it is over 20 million new cases in 2022. And the projection is 35 million new cases per year in 2050. That is, there will be 75% increase of cancer incidence compared to the year 2022. This is really alarming, and that's why it is imperative to discuss the issues with cancer care and also the expenses, how to reduce the expenses. So thank you very much for your patient hearing. Now I have the honor to request Professor 𝗕𝗓𝗄𝗃, Department of Economics, Khulna University. You are requested to give some insights on financial burden of cancer care on patients and families. Financial burden on cancer care on patients.
Thank you so much for giving me the opportunity. I'm really
Professor
feeling.
You have only 5 minutes time.
Yes, definitely. I know.
Thank you.
Actually, if we concentrate on the economic burden of cancer, my field of interest was to work on the financial protection mechanism. How could we uh, help our cancer patients to overcome the economic burden of cancer. There are lots of ways through which we can explain the economic burden of cancer. Uh, the incidence of catastrophic health expenditure, the incidence of distress financing, and the incidence of organ care. If we concentrate on the economic burden of cancer, first one is our people are facing 50% of the patients in our country are facing catastrophic health expenditure. Catastrophic health expenditure refers to a situation when the families have to pay 40% of their total consumption expenditure for health treatment purpose, which compel them to reduce or deduct the other expenses on their daily necessities and just put them or turn them under below poverty line, that means impoverishment. Another impact is whenever as there is only 0.2% insurance coverage in Bangladesh, we all know that cancer is really extremely expensive treatment. So to pay for this, our people are mainly facing distress financing. Distress financing occurs when the people normally sell assets or go for loan or go for donation. This simple sale of assets is simple to hear, but these assets actually include either their homestead where they live or the arable land which is the source of their income. So to pay for cancer care, 50% of the people of our cancer patients or their families are facing this catastrophic expenditure. So these are the only the financial burden. We all know that there are also some economic and social and other burden, that means some indirect burden. So why this burden? Why the burden is so acute for us? Because there is no health insurance mechanism in our country, and the OOP is considerably high. The main reason or the main sources why the OOP is high is actually the cost of hospitalization, the cost of chemotherapy, and the cost of surgery. So if we really want to pull our patients out of catastrophic health expenditure, we have to reduce these out-of-pocket payments. We have to reduce, or we have to we have to put more attention on prevention and screening rather than curative care. That's all for me. Thank you.
Okay, thank you, Professor 𝗖𝗂𝗁𝗲. It was really interesting information you gave us that more than 50% of the patients are facing the catastrophic health expenditure. So it is a very, very big problem for Bangladesh. And we do not have health insurance, that is another problem. So whether Dr. 𝗱𝗏𝗏 Shahriar has joined? I can't see him now.
Yes, I have joined.
Oh, thank you very much. You are most welcome.
Right, thank you.
Already introduced you. I have read out your CV. Well, I don't know whether you were.
Yeah, I heard it.
Okay, thank you so much.
Right.
Thank you so much. And now, after Professor 𝗖𝗂𝗁𝗲, your turn comes. And we want to listen from you on the how physicians can play a role in reducing the cost of cancer care on individual patients.
Okay, thank you very much.
Did you get me?
Yeah, yes. Thank you very much. Yes, just to inform you that when we start to treat patient, before that, we have to have some informations like, what is this, what kind of cancer, and what is the grade, what is the stage. And this, to find out this, there are a lot of examinations. So, we have to stratify on which patient what exam to give according to their ability, financial ability. Like, we can go for PET-CT for staging. We can go for whole body CT scan for staging if the patient is very able, no need of any charity or anything like that. But for those poor patients, we don't have, we cannot go for these expensive tests. These are expensive tests. So if we go for this test, ultimately the patients cannot get the treatment, but treatment, they also are costly. So doing examinations, we have to be careful that, yes, after examination, they should be able to get the proper treatment. So, for CT scan, we can go for X-ray, ultrasonogram, even though they are not that much comparable, but, they can give us a gross picture of the stage of the disease. And then, we can skip some expensive tests, but in that case, we may miss something also. So we have to balance this acts of saving money for the poor patients. And as much as possible, we have to guide them why to get this test cheaper, like, there are investigations done in the hospital, government hospital. They sometimes, they're, very subsidized, and they can go to the private centers. Among the private centers, which are good, but which are, affordable, more affordable for that patient, that physicians can guide these patients in that way. Then, when we go for the treatment, we know the stage and all these things. Then, there is a new concept now, managing the patient personal management. Then, it's a unique, the patient is a unique thing, and this patient might have some molecular variant. And to know that, NGS and all these very expensive tests has come into existence for nowadays. So it is useless to think about NGS in a poor patient. But for those who can afford, yes, we can go for NGS, and then we can, just, pinpoint the tier 1 treatment, tier 2 treatment, or tier 3 treatment for this particular case. There are at least 11 cancers now that guidelines suggest that you go for the NGS study. Number one, the comprehensive NGS study is not done yet in Bangladesh. Some organ-based studies are in existence in 𝗖𝗂𝗏 and also in burden. They are also coming up. For a poor patient, we can go for those tests, which are costly, but compared to the comprehensive testing, they are not at all costly. They may cost you 3 lakh, 4 lakh taka, but this test will cost you 20,000 taka. So in that case, we can, guide the patient for this kind of test, where to go, so that we have the necessary, but, limited, but necessary informations to treat this patient. And tier 1 treatment is possible, if possible, from the patient. We go for the tier 1. If it is expensive, then we go for the tier 2. If that is also expensive, go for the tier 3. Sometimes, we go for the previous treatment, like, 5 years back, which was the standard treatment. This patient, current treatment he cannot afford. So we have to treat the patient. So we note down the situation that this patient cannot afford due to this economic burden. So we went into the previous guideline-based treatment. So that is also effective in many cases. So in that way, we can also save money and offer the treatment to the patient. So these are all that I do. And also another thing, we do, we're expensive center. We can get all the information in the ways that I have just mentioned. Then we suggest the treatment, and we send the patient to an more affordable center where they can get the treatment. They cannot get the treatment in a 𝗲𝗂𝗏 hospital due to the burden of the treatment and everything. But they can go to some other center following our guideline. So we often play a role as a reference center. We give all the information, we give all the direction, so the patient can go elsewhere where he or she can afford the treatment. And in that way, they can save money and then get a proper treatment. So these are the things that we are doing and we can do. Thank you very much.
Thank you. Thank you, Dr. Firdaus Shahriar. It was quite interesting, whatever you have shared with us. And what I understood is it is very important on the part of physician to guide the patient to tell him where he or she can go, because when the patient come to know that he or she is suffering from cancer, then he or his family, her family become puzzled and baffled. At that time they need help from the doctor, and that first help is to guide them where to go and where they will not suffer from catastrophic health expenditure. So thank you very much. Definitely, the participants have some queries or questions. They will be asking questions or sending the reflections in the chat box. And in the developed countries, there have been a lot of developments in cancer treatment. And Canada is also one of the most developed countries. And Alex Barland is working there and also working in Bangladesh for a long time. So, Alex, I would like to request you to share your experience, the Canadian experience, on cost of cancer care. Alex Barland, please.
Thank you for that. Yeah, I appreciate the opportunity to be here. I will try to be brief, and I'll start by saying, I don't know a lot about cancer care in Bangladesh. So the first thing I did was to look for the literature, look at the evidence, and I came across this interesting paper that gave me what I needed for an overview. Trying to take a systems perspective. I'm a health systems person. I'm not a cancer person. And so this paper, I don't know if it's in an excellent journal. It's impressive qualifications of the people who are involved. But if I were taking a consulting job to analyze the cancer situation, the cost of cancer in Bangladesh, I would want to do a validation process. And so I'd take something like this well-written paper and go out to the public and the profession and ask, so what can we add and discuss and so on. So I'm not pretending this is a big evidence-based study. It's my sort of quick response to a request to participate. So this paper I thought was actually really interesting and very well written. Let me just focus on the priorities that they list here, because it gave me a good orientation to some of the issues. And thinking about costs, especially catastrophic costs, I don't think there is a simple, easy solution. Professor 𝗕𝗏𝗏, Professor 𝗱𝗏𝗏𝗏 have both told us many important things about aspects of the problem. And so thinking about how we might tackle it was helpful to see what might be feasible. These authors, the Islam and this group, they're looking at cancer care overall, not just costs. But I thought many of these issues that they refer to actually have quite a lot to do with managing costs. So I'm just going to quickly go through each of their 6 priorities that they recommend. So the first of them, from a Canadian perspective, the first of them is governance. And this is a very important issue in Canada as well. Of course, everyone's talking about governance. We have a system here where cancer care is very often delivered by regional centers, division level in Bangladesh, or further down. And so these regional centers provide guidelines. They have a certain amount of influence because they provide the medications, usually free of cost, to people who are following the guidelines. And so I think that's one of the first important things to think about from a system or a government perspective is, for one piece of the puzzle with the medication costs, is there some way to generate a special program that focuses on providing medications or some other aspect of treatment? This is really about governance, and you can see I've referred here to a document, a Canadian document of recommendations of what they call implementation planning. And I put a big pink arrow on this word implementation. Implementation is about getting things done. And I will be very honest with you. My observation in Bangladesh is that there are excellent documents about what to do and how to do it, and smart people thinking about these problems, and they publish reports and recommendations and plans. And honestly, the results are disappointing. The follow through is weak. The implementation is not strong. And I think that's an area where really, I guess, my main focus is, yes, we can agree that there's a problem with cost, but is anybody going to do anything about it? And so here I'm showing the groups that are involved in Canada, and I'll talk a little bit more about that later. Financing. We spoke, previous speakers mentioned the cost of drugs. This is the process that we go through in Canada. It doesn't really matter exactly how it works, but it is quite a tightly organized process to approve new drugs. The beginning part, as you can see, I won't go into all the detail, but you can see it starts and at the same time, some local independence for the people who actually have to spend the money. Collaboration is a very important aspect of this program in Canada. I'll just jump back to my earlier slide. You can see this recommendations for implementation planning, this document I'm referring to. You can see this three big organizations: Cancer Research Alliance, Canadian Partnership Against Cancer, Association of Cancer Agencies. That's the delivery arm of this program. This collaboration is very important. And one of those was the Canadian Partnership Against Cancer. So again, this is how we in Canada bring together the stakeholders, we would call them, the people who are delivering care, doing the diagnostic work, the pharmaceutical producers, the equipment manufacturers, patient groups, perhaps poverty action groups, to come up with a continuum strategy that looks at all aspects of cancer, from screening to palliative care, and thinking about how that might be managed in a more coordinated way. The fourth recommendation from this Bangladeshi paper is a national cancer registry. This is a very important way of generating data and evidence. We have in Canada, we have various kinds of registries. I don't know the status of registry development in Bangladesh, but again, this is a way in which central government can provide support in a very important sector of care, very expensive, big patient impact area, which without a huge expense, these things, of course, they cost money, but they provide so much value in order to be able to track progress, evaluate the effectiveness of different policy changes. This issue of access to specialized care, Professor Qinis referred to this in terms of cancer prevention and screening. I know that the cervical cancer screening program has been enhanced and supported recently. We have the HPV immunization program underway. These are obviously ways in which we look to actually preventing illness in the first place. Telehealth is something that we use in Canada for a different reason from how it may be helpful in Bangladesh. In Canada, we have small hospitals, a small population over a very large area. Telehealth allows us to bring specialist support to family doctors working in small towns away from big hospital centers. Dr. Felhdusarian referred to this as well in terms of providing guidance to less expensive programs. And so this telehealth idea, using Zoom technology, among other technologies, but Zoom, for instance, to bring specialist help to small areas that cannot support a full cancer program. Thinking about the financial burden for patients and families, this is a social welfare problem. But the point here is one of the things that we think about in Canada is not just the cost of medical treatment, but also the cost for certain families, not for everybody, but for losing their income from employment, and the cost of transportation and going to another city and having to stay in a hotel during the treatment. So we have volunteer agencies, we have NGOs that support patients with some of these other costs. And the final area with access to specialized care is how can we see more patients, provide more treatment using the same resources? And this has been a push in Canada for a long time. We have an expensive system, this constant management pressure to improve efficiency. And so this is an obvious area to think about it in any system. And the final area I wanted to speak to is the paper's reference to enhancing research capabilities. And one of the things that our Canadian Research Alliance, this group here at the bottom of the slide, talks about is building capacity in implementation research. Implementation research. So there's that implementation word again, my big pink arrow for every discussion I have about what's going on in Bangladesh is implementation, getting to action. And particularly for the Canadian perspective, what I thought was important, this reference here, an innovative approach to capture the interest of young people to work in this field. So I'll close with that. I think that's just as relevant in Bangladesh as it is in Canada. Bangladesh has the advantage of a young population and lots of young scientists, young medical practitioners. And so I think that's where things might be carried forward. I'll stop there.
Thank you very much. So comprehensive information. Thank you, Alex, for selecting very good article and sharing with us. And since I worked in the government for a long time, I am of the same opinion that on documents we are excellent. We have very nice, laws, rules, acts, but in case of implementation, we are not up to the mark. And actually, implementation is a word, but it's very difficult to implement. Implementation science is there, so we have to understand how to implement things. But still, collaboration, as you have mentioned, that is very important for facing this kind of big challenges. So this time, I have the honor to request Dr. 𝗕𝗲𝗋𝗶, Senior Consultant, Anatomical Pathology, Singapore General Hospital. Please share with us your insights on how cancer care cost is contained through high quality pathology compared to lower and middle income countries. Dr. 𝗕𝗲𝗋𝗶.
Thank you very much for kind introduction and for inviting me to this webinar. Can you see my screen? I don't know.
Yeah, we can see, but the screen is small.
Can you see now? So,
not yet, sir.
Sorry?
Not yet. You don't see your screen.
Not sure why.
Okay, well, we see the screen, but
what
it is
we can
different
see is a
page.
list of things,
Oh, okay. So
now you can share.
Please, can you see now?
Yes.
Yes.
Okay.
Perfect.
Okay. So as I wish to discuss, because the pathologist, the role of pathology in cancer care is a topic of my interest, and I don't want to go into the details of cancer care financing because Dr. Berlin has spoken a lot about cancer care in Canada, and it's quite, I wouldn't say similar, but comparable in Singapore because it has both government and private financing, with the government sector providing the most support for patients, for cancer patients. And they have this cancer drug list that the government has approved recently, very recently, I think a few years back. So patients who receive cancer drugs from that list are mostly subsidized. And so there are other subsidies for patients. And I would say most of the patients who need financial support receive adequate assistance in some form, whether it's private or government. Unfortunately, the same cannot be said about Bangladesh. But the one thing that I wanted to point out is that in developed countries, the cancer care, the cost of cancer care is predicated on the accurate diagnosis of the cancer. Right? So if you have appropriate diagnosis, then the treatment will also be appropriate. If you don't have accurate diagnosis or facilities for accurate diagnosis, then of course that will affect the patient care significantly. And for cancer care, I think the cost starts the moment the patient goes for a biopsy. So in Bangladesh, I've seen some statistics which say that around 5% of the total cost, cancer care cost, goes into pathology diagnosis. So it's only 5%, whereas the rest of the cancer care cost comes from surgery, chemotherapy, and other stages of management. So if you look at these various steps, if the diagnosis is not accurate, this will consequently affect all stages of treatment, and that means it will affect the financing also. So if you have, for example, if you have a wrong diagnosis or underdiagnosis, that can lead to inflated costs at the long run. If you have a false diagnosis, that can lead to also financial cost, but which is unnecessary. The other thing that is, and this is from my own experience, the pathology labs are not very well developed in Bangladesh. In most of the labs, the efficient ones are centered within the capital and few other cities. Beyond that, you don't have much facilities for ancillary testing that are now, which are essential for proper diagnosis, histologic diagnosis of cancer. So you don't have enough trained workforce, pathologists or healthcare professionals. And I think this is one area where the government should focus on training manpower. And last year there was this Health Reform Commission report, which I tried to read through it, and it was quite an elaborate list of suggestions, mostly aimed at improving the delivery of treatment. But it actually, when I looked into it in depth, didn't focus much on the laboratory aspect of treatment. So I think that indicates that there's a lack of focus on pathology and laboratory medicine in our country. And this should be addressed, I think, immediately and with great importance. So when you have all these cancer control programs, like cancer screening, which has obviously led to increased incidence of certain cancer because of increased detection, you need corresponding efficient pathology care facilities too. So that needs strong support from the government. And the other thing that I think the investment in health sector, which includes the laboratory pathology and laboratory medicine, is also I think a sort of incentive for both the survival and the economic sustainability of the country. Because in the long run, good pathology lab system will help cancer patients substantially. If you have accurate diagnosis, then you can have accurate treatment also. And the last point I wanted to make is from Dr. Berlin's discussion. He mentioned about cancer registries. Yeah, unfortunately, we don't have any national, in a true sense, the National Cancer Registry in Bangladesh. There are few registries, I think, which are based mostly on at hospitals. I know there are few registries which are based on the BMU, the Bangladesh Medical University. There's another one, the National Cancer Hospital. They have some registries, but these are not like comprehensive. So I think this is something that should be considered strongly, and government funding should go into cancer registries also. So I think with all this, I would like to conclude my session. Thank you very much for your attention.
Thank you, Dr. Javed. It was really an eye-opening discussion. At least it was eye-opening for me, because I was astonished to know that only 5% of the total cancer treatment expenditure is done for the diagnosis, and 95% is for other reasons. So really it is interesting, and accurate diagnosis will lead to accurate treatment. So if we have done any mistake in diagnosis, then treatment will not be good. So this time I would like to invite Professor Sheikh Nazmul Huda, Chairman of Public Health, IUBAT. Please share your insights on the role of academia in optimizing cost of cancer care. Professor Sheikh Nazmul Huda, Professor Dr. Nazmul Huda.
Honorable Chairperson, respected moderator, sir, learned panelist, and my students and colleagues. The time is very short, but we have a very, what should I say, comprehensive topic today to learn from each other's thoughts. So just I would like to give a little background of this topic of this of today's webinar. February 4th is the World Cancer Day. So this year, the theme is a little bit different. It is cancer journey is unique, like that. So, but I think in context of Bangladesh, where many people cannot afford or cannot complete the cancer treatment, remain undiagnosed, die of cancer, remain as a patient undiagnosed. So perhaps, the cost of care for cancer in Bangladesh is an important area to contribute on this day. So as a teacher, public health, I'd like to just highlight one thing first. That is the data gap. There is very little data about how the cancer is spending from the government and from individual person, families and patient, how they meet the expenses and where there is a scope to optimize for optimization of resource utilization. So that is very important. We, in Bangladesh, our out-of-pocket expenditure for health is 70% about, but about cancer, there is no data that in cancer care, how much we spend from our pocket. So that is one thing. And there is no data about catastrophic health expenditure, incidence of catastrophic health expenditure. Though the measurement of catastrophic health expenditure for cancer is very difficult because of the kind of data system, health information system is not that robust and it is complex. So it is very difficult to come to some conclusion that how much a family actually spend for cancer care. So, but I think what might be important and what is doable, that is we need disaggregated data. For example, if you look at the cancer care cost at USA, Canada, and many other countries, we have seen the disaggregated data. From disaggregated data, you understand that how much they are spending before diagnosis, how much they are spending in the last 5%, last year of how much they're spending. So you can think about how we can further rationalize that is, using money for treatment. So for example, as a physician, I have observed that many people, they finish their, everything before they come to a hospital. They just keep on circulating from one doctor to another doctor. The absolute, kind of lack of triage system in Bangladesh, that how to refer a patient to the right place. And before going to the right place, he, whatever he collected money through selling his last piece of land, it is exhausted before coming to the right place. So that is one thing I think Professor Jia is from National Institute of Preventive Social Medicine, NIPSOM. We are also here from IUBAT and my colleagues from other academic institutions. I think Professor Kanis from Khulna University, we can encourage our students to do their thesis on for generating disaggregated cancer care financial data, so that can set the ground of further comprehensive research to understand the thing. So that is, I would like to introduce one thing to you as food for thoughts to this special audience, that is the political economy of cancer care. And the political economy of cancer care, it involves the interplay of government policy, the corporate interest, and socio-economic factors that dictate the funding, pricing, accessibility of cancer treatment and prevention. It is important because when millions of people are dying out of cancer without taking proper care, the companies, their revenue generation has been increased 90% in a time span out of the cancer drug. So you can imagine. So the marketing, the aggressive marketing of the large hospitals, of the corporations, of the pharmaceutical industries, that is attracting people for spending more, maybe for a small benefit. I was reading a paper. That paper was actually written by the executives of many companies, senior executives, and they are claiming this, that in Europe and other countries, they're raising voice that it should not go unchallenged. The price and at what benefit it offer, the price of drug. And is it possible to rationalize that investment? So that is the scope, and how Bangladesh government, what capacity we have, what leadership we have to regulate this mushrooming private sector.